Welcome to this neuroimaging tutorial. Today we are looking at MR angiography of the brain, a non-invasive imaging technique that helps us to visualize the blood vessels of the brain without contrast. This video is designed for medical students, interns and early residents who want to learn how to understand and interpret MRA brain studies, especially in the context of stroke, aneurysm and vascular anomalies. So we will study into 4 sections. In section 1, we begin with the basics. What is a MRA and why do we use it? MRA stands for magnetic resonance angiography. It is a non-invasive imaging technique that visualizes blood vessels. In MRA, uses a special sequence which is time of flight or TOF for brain studies that enhances flowing blood, allowing us to see arteries clearly. If we talk about basic principle of TOF, it relies on the difference between flowing blood and stationary tissue. Fresh blood flowing into the imaging slice has not been exposed to prior RF pulses, so it appears bright compared to surrounding static tissue, which becomes saturated and appears darker. So I am explaining step by step the physics of TOF sequence. Firstly, saturation of static tissue. The imaging slice is repeatedly excited by RF pulses. Stationary tissue within the slices become saturated and reducing their signal, so they appear darker. Secondly, inflow of unsaturated spins. Blood flowing into the slice brings fresh and unsaturated protons. These spins have full longitudinal magnetization. They produce high signal on the next RF pulse, which result blood appears bright, vessels are highlighted. So I am showing key technical feature chart on the screen in which parameters mentioned along with details. First one is the sequence type. This is a gradient echo or GRE type sequence which is known for the flow. Direction must be perpendicular to the imaging plane. Example, axial, TOF or circle of Willis. Flip angle must be small to moderate. TR and TE must be short, and also apply saturation band to suppress the venous flow if only artery is needed. Next is the use of TOF. It is particularly used for detecting aneurysm, evaluating arterial stenosis, investigating vascular malformation like AVM, assessing occlusions in the stroke patients, and many more. So come to the section 2. In section 2, take a look at the normal MRA of brain. The circle of Willis is the central hub of the brain's arterial supply. On MRA, you should be able to identify internal carotid arteries, which is ICA. These enter the brain and bifurcate. Then middle cerebral artery, MCA, extending laterally both sides. Then anterior cerebral arteries, which is ACA, moving forward and medially. Then posterior communicating artery, PCOA. Then posterior cerebral arteries, PCA. So you may also see the basilar artery formed by vertebral arteries and its bifurcation into the PCAs. A complete circle of Willis is not always seen. Anatomic variants are common and often asymptomatic. So come to the next section. This is the section 3, common pathologies on the MRA. Now let's look at some common abnormalities that MRA can detect. First one is the intracranial aneurysm. It appears as a rounded outpouching from an artery, often at bifurcations, most commonly seen at the anterior communicating artery or MCA bifurcation. Second one is the arterial stenosis or occlusions. This could be seen as narrowing or loss of signal in the segment of the artery, common in ischemic stroke, especially in elderly or hypertensive patient. Third one is the arteriovenous malformation or AVM. Appears as a tangled mass of vessels. MRA can detect large AVMs, but DSA, digital subtraction angiography, is more sensitive. Then fourth one is the Moyamoya disease. It is characterized by stenosis of ICA and puff of smoke, collaterals, classic appearance on MRA. Then come to the section 4, which is related with the planning of TOF sequence. So before starting the planning of MRA, we must have knowledge about the contraindication of MRA brain, patient preparation and consent sign. I already make a video on the contraindication, patient preparation and consent sign. You can watch it in my previous videos. So firstly, we position the patient after completing all formalities. Lie down the patient on the table with supine position. Place the head coil on the head of the patient and cushions for immobilization. Also give cushions under the leg for extra comfort. Center the laser beam localizer over the glabella. Now come to the planning. A 3-plane localizer must be taken at the beginning. Then plan any of the axial. It might be axial T2 weighted, T2 flare, axial T1 or diffusion as per your radiologist requirement. So go to the plan TOF sequence. Plan the axial 3D block on the sag plane, angling the planning block parallel to the genu and splenium of the corpus callosum. Ensure that the slices are sufficient to cover the entire circle of Willis. Verify the planning block in the other 2 planes. Ensure appropriate angle is maintained in the coronal plane perpendicular to the line of third ventricle and brainstem. To reduce venous contamination in the resulting imaging TOF sequence, use saturation band on the top of axial block. After completing TOF sequence, we will see the result in MIP image. So that's it. If you found this video helpful, please like, subscribe and hit the notification bell so you don't miss my upcoming tutorial.